Thanks very much, Steve. It's a pleasure to be here. Danny, thank you for the invitation. Okay. Yeah. Clicking. All right, here we go. I went through disclosures. They won't be pertinent to this. I work with most of the hernia-related companies, though. When we talk about technology of the future or multidisciplinary teams, it's a little bit different in this talk. We're going to talk about how to apply that to the patient and the patient groups. And to understand this, I went through some of the themes. We're going to talk about reductionist science, reductionist mindset, complexity, the increasing complexity in our world, and how we're evolving our understanding of how to apply system science to our organizational structures, and in our case, in healthcare. It really starts with going back to the Renaissance, and this is Isaac Newton, and the illustration is that of the scientific method. And here, if you can control all the variables and test two things, you can find the right answer. And this has really benefited our world, obviously, through the Industrial Revolution and up through the 20th century. But I would suggest that there's some incompleteness when we apply this to complex biologic systems like human beings. And part of the problem of the diminishing returns we're getting with that reductionist science is the fact that things are increasing faster and faster. Complexity is increasing faster and faster. And you're seeing some of these technologies just explode in our world, but our system structures and our thinking and our reductionist mindset may be inhibiting this. And what happens with increasing complexity with organizations designed in reductionist science principles is you get more and more fragmentation. With the increasing complexity, and we've seen this in healthcare, we get more and more department silos in our hospitals. We have more and more divisions competing for resources. And this is predictable because of the increasing complexity. You also have more bureaucracy. It's harder and harder to be efficient when there's more and more fragmentation. And so the top of the chain, at the top of the hierarchy, it's harder and harder to have the knowledge of what's going on the front lines, and it makes it very difficult to have information to make decisions. And in our system structure for our physician model, we're built around the physician, the individual physician practice model. And that leads to some inefficiencies, especially with this increasing complexity and increasing medical knowledge. This is the date where the 20 millionth publication on PubMed was published. And one publication per minute comes out after that. And I don't know about you, but I'm not that quick a reader to keep up. And this is a graphic representation of that. And this is a study in primary care physicians. The red spikes are how much medical knowledge a primary care physician is required to know to make one evidence-based clinical treatment decision. And the top green line is actually the maximum human cognitive capacity. So it's getting very fast, inappropriate or not realistic for individual humans, physicians, any human being, to have as much medical knowledge required to make these decisions. And no matter how much technology, how much training we get, we're still human beings. We're still going to make errors. We're still going to make mistakes. And this is something we can't avoid. And this is why we're going to need to go to teams. And on another note, pushing us faster and faster because of this increasing complexity and the financial stresses in our individual physician model. This was almost 15 years ago published about hamster healthcare, trying to run faster and faster on the hamster wheel, and I would suggest it's not sustainable. And on a more serious note, this is a study that came out of the American College of Surgeons in 2009, and it surveyed over 4,000 general surgeons and found 43% of general surgeons are in active burnout, and a full third of us are clinically depressed. And I would suggest that's not our personal failures. I would suggest that that's a system result, this increasing complexity in a system design that's not sustainable. And I would suggest that if we think differently, if we can apply more robust, complex system science, we may have some innovative solutions to some of these problems. And I think this is what Einstein was talking about 100 years ago, as he was beginning to see the incompleteness of the Newtonian physics and began to look into quantum mechanics, theory of relativity. And he foresaw some of the problems we're experiencing with our organizations and industries designed in reductionist science principles. And he said, we're not going to be able to solve these problems using the same kind of thinking we've had. And basically, it's understanding of mechanical system structures and how mechanical systems are improved and maximize versus complex biologic systems. In a mechanical system, there's a linear cause and effect that's predictable. In complex biologic systems, that's not the case. And unfortunately, for us in healthcare, our patients and ourselves, we're complex biologic systems. We look more like this, with many inputs and interrelations of those inputs and many things going on, interrelating within ourselves and within our organizations. And the outputs are not predictable, they're multiple, and they feed back on the inputs to have, again, unpredictable results. And so the same kind of system solutions that work in a mechanical system, like standardization, in the case I'm going to talk about, like hernia mesh standardization, can produce less waste and better outcomes in a mechanical system, but the same principles of standardization in a complex biologic system will produce more variation and in some cases unintended harm. And so what we've done, what we're working on, is applying these complex system science principles to build multidisciplinary teams around definable patient groups, in this case hernia disease, hernia patients, and just to show the point, some of our core team members here, that we have a multidisciplinary team. In fact, in our core team around our hernia patients, we have an ex-flight attendant, 2 engineers, a organizational design psychologist, a writer, a mom, a student, and in fact, I'm the only person in that picture who has any formal healthcare training. That's the diversity that we need to apply in complex systems. And so what do these teams do? We do basically 2 things, care coordination and clinical quality improvement. And I'll show you what that has been interpreted, at least in our teams. And that care coordination is having the team care for the patient through their entire cycle of care. And people on the team, we term patient care managers, developing loving, caring relationships with the patient and family so that they can help them manage that entire process of care. And there's beginning to have evidence come out with this kind of a model. This comes from the Kaiser system, where patients who had myocardial infarctions were followed for 10 years. And the top green line is when they were followed in a care team with care coordination, and you see a 90% survival rate. The red line is the patients that went to standard physician-based practices and did physician clinic follow-up, and the survival rate was 25%. That impact is huge potential. The other thing that the team does is continuous clinical quality improvement, where the processes are defined from the entire cycle of care around the patient, and then outcomes measures that measure value are monitored, measured, and then used to improve the processes. Now, it's messy at first. Mapping out these complex processes for the entire cycle of care takes some time, and I would say the teams and the putting patients in the processes and learning from the patients and learning from the processes doesn't always go perfectly well. There's going to be errors, there's going to be complications. A team that can do amazing things, work together to overcome problems, bad situations, also will have to learn from their errors and learn how to learn from their errors. And this is part of the real complex world that we live in. And again, on another serious note, many of you may have read this Time article called Bitter Pill, and this looked at the hospitals' charging and billing practices and the fact that most hospitals, if any, don't know what it costs for entire cycle of care for a definable patient process like hernia repair. And if we need to be driven by value, we need to understand what it costs in the process. We also need to look at quality measures and outcomes measures, patient satisfaction. But if we don't know what a process costs, we can't measure value. And so this article comes out of Harvard Business Review in 2011. It's Porter and Kaplan. They have a very in-depth design for how we should measure costs and value in our patient processes. And we've been applying these principles. This isn't the only resource, but it's one of the better resources. And with this kind of process, with our engineers, we've mapped out the entire process of care. This is a ventral hernia process. And within this process, we're defining process measures we think matter to the outcomes, patient variables, process variables, technique, mesh, things like that. But we're also measuring costs so we can understand the real value-based outcomes of these processes of care. And from this, we can begin to apply principles of complex science research. Which mesh is best for which type of patient? Traditional research can't do this. Traditional research and reductionist science models are absolutely valuable, and we've all benefited from that. But as we get to a more complex world, and in the real world of patient care, we need to apply these complex systems type principles like continuous quality improvement. And this is a team approach, and continuous learning that's driven by the value-based outcomes. And so we're looking at things like hernia mesh variability. We've explanted over 400 pieces of mesh and looked at it to see what happens in which different types of patient subpopulations. We do a variety of analytics from thermal, chemical, mechanical, histopathologic, and one of the tests we look at is compliance. We push a mesh through a slot at a constant rate to look at the force required to deform that mesh, and we see an incredible variability. Some patient clusters have almost the same compliance as when it's out of the package, very good compliance. Others have a moderate amount of stiffness, and some have tens of thousands of times more work required to bend that mesh. But this is not a two-dimensional bell curve, this is very multi-dimensional. We also see patients, in a lot of patients, heavyweight polypropylene getting degraded and frayed. But in some patients, this is a 14-year explant, the polypropylene is completely pristine. These patient subpopulations we need to try to identify to match the right mesh for the right patient. And to learn more about this, I would ask you to take a look at YouTube and Malcolm Gladwell's TED Talk on spaghetti sauce. And he talks about Howard Moskowitz and how he learned this and applied complexity science principles to the consumer food industry almost 40 years ago. And he learned there's not one best spaghetti sauce, is that people cluster in different tastes for spaghetti sauce. So there's just multiple best spaghetti sauces, and we can put the same principles around hernia meshes or hernia techniques. And so the data comes out not in that two-dimensional bell curve, but in multi-dimensional data. And at first it looks pretty messy, but over time you can see clusters. And it's in these clusters that we can begin to predict which patient subpopulations do better or worse with which meshes and which hernia techniques. And this is a computer-generated representation of complex adaptive systems. And you can see real clearly that it never stops. It's not static. It's constantly moving. But you can also see something else. We do tend to cluster. And with data over time, we can begin to be better predictive about how we take care of our patients. And so this data analytics, this is not the end point. The data needs to be interpreted by a team who understands the process, a team who works with patients, and we have patients and family members on the team, and then the team takes that data and applies it back to the process improvement ideas. And that's where the innovation opportunities really start to come. And then over time, we can begin to see the right mesh for the right patient and the right technique and the right value. And finally, we need to also work outside of our teams, down the value stream and up the value stream with the producers of these products and outside of healthcare. We can go outside of healthcare to communities. There are many patient communities now who are passionate and very knowledgeable about things like hernia and all of the diseases because these patients have these diseases. And working in networks, group to group, we can have much more innovation and value than working within our own silos. And this is just scratching the surface, but this comes from the HIV research and a group that looked at an RNA protein, and they couldn't map it out. And they wanted to map it out to try to get drug ideas. And for over a decade, multiple labs tried this. Millions of dollars were spent. And finally, a researcher out of Washington University sent it out online to the gaming community. And the folded gaming community solved the problem in 3 weeks for free. And you can see the authors, third and fourth authors, are folded gaming community groups. So I think this is the potential, and we're just scratching the surface. We care. The problem isn't the people. We care desperately about our patients, but we don't know which is the right mesh and the right technique for which patient, but we can learn. I think if we change our thinking, we apply complex system science to our multidisciplinary teams around patient groups. I want to thank you for your attention.
Thank you, Bruce, for a very stimulating talk. I'd like to thank all of you for participating this afternoon and taking the time to be with us. Thank you.